And one more time, join Kyoto 27th of March to 31st of March for the upcoming APASL meeting. Thank you. Over to our moderators.
Professor Yaswant.
Good afternoon. Thank you for the invitation as a moderator, Professor Sharin, Professor Sina, Professor Joslao, and all the member of the ALCAP team, Dr. Ashok. And today program, we have three programs. And first, we are starting with the grand round by Professor Won Mok Choi. So the allocation time for the program is 15 minutes for presentation and 30 minutes for discussion. So the time is yours, Dr. Mok, please.
Okay, thank you so much for the introduction. I'm Won Mok Choi, working as an assistant professor in the Department of Gastroenterology at a medical center. So I would like to express my gratitude to the committee members of APASL RCAP for providing me with the opportunity to present a case. Today, I have prepared a case on advanced HCC without typical imaging findings. This patient is a 53-year-old male who had been a chronic alcohol consumer, drinking 1 bottle of soju, a Korean traditional liquor, 3 times a week for nearly 15 years. He presented to a local clinic with complaints of fever, nausea, and epigastric pain. A blood test and a CT scan were performed, which revealed 15-centimeter large liver mass leading to the referral to our hospital. In the blood test, the platelet count was normal at 314,000, and albumin was also within the normal range at 3.8. Total bilirubin was also normal at 0.6, and prothrombin was 85.2%, and there were no signs of ascites or encephalopathy. Overall, his child score was A5. Tumor markers were elevated at elevated levels of AFP of 2,340 and PIVCA2 at 54,352. For CA and CA99 were within normal limits. All vital markers, including surface antigen, co-antibody, and anti-HCV, were negative. As you can see in the CT scan, a 15.4 centimeter mesh showing rim arterial pace hyperenhancement was observed in the right hemiliver, with no definite washout on portal venous pace. In addition, several other arterial hyperenhanced masses were identified in left hemiliver, none of which exhibited portal venous washout. Mild bile-duct dilatation was noted in right posterior section of the liver, possibly caused by extrinsic compression from the tumor. No definite tumor thrombus was observed in portal and hepatic veins. Therefore, his B-cells stage was B, and the modified UICC corresponded to 3, with a large LRM mass with multiple intrahepatic metastasis. Okay, then what would be the appropriate next step or treatment for this patient? Should he proceed with liver MRI or PET-CT scan? Or should he consider performing a biopsy? And is it possible to confirm HCC without additional test? I want to hear your opinion.
Yeah, maybe from the panelists have opinion.
Yeah, in our place, we will do the PET-CT scan with the C11 acetate to help us to define the nature of the lesions and whether there is any spread beyond the lesions identified on the CT scan.
I agree with Dr. Low. Agree with him.
So the PET or CT scan, yeah.
So one more information, we took chest CT, but there were no metastasis. Do we still need PET CT scans for these cases?
Well, it's our practice. I mean, we want to see whether there is any other undetectable metastasis, because the tumors shown on the CT scan is very, very big. So we in such an instance, metastasis needs to be carefully evaluated, because this would affect the management of the patients.
I may consider doing a primo-based MRI because it might characterize the tumor better. Because if you already have a chest CT and no metastasis, maybe we should characterize whether it is steatotic or it is a different type of tumor. Maybe Dr. Yashwant can advise more. He is an expert on radiology. Maybe you can proceed if no comments, please.
So yeah, as you know, the opinion are a little bit divergent, but while the patients does not fall under LIDAR's categorization due to the absence of definite risk factors, the tumor would be classified as an LIDAR's category M tumor, and this category is characterized by definitely malignant but not HCC specific, and tumors showing at least one targetary appearance or non-LR5 tumors with additional findings as described here, fall into the LRM category. So our tumor displays limb arterial pace hyperenhancement, a key feature aligning with the LRM criteria. And as you can see in this figure, the AASLD and LIRAS in consensus suggest multidisciplinary discussion for tailored workup for LRM tumors, which includes biopsy in most cases. So we performed the liver biopsy and for confirming the diagnosis, and upon examination at low magnification, most of the tissue appeared to be necrotic tumor tissue with fiber tumor comprising less than 5%. When viewed at high magnification, the tumor cells exhibit a compact arrangement with deeply eosinophilic or clear cytoplasm and showed high-grade nuclear atypia, quite comparable with poorly differentiated hepatocellular carcinoma. In the immunohistochemistry examination, although CK7 and CK19 were confirmed as focal positive, these findings are commonly observed in HCC. In addition, AFP and HEPA1 exhibited focal positive staining. So let's have a short discussion before moving forward. So if a patient had hepatitis B virus infection and elevated tumor markers such as AFP and PIVKA2, where the likelihood of HCC is very high, even in the absence of typical HCC findings on imaging, would you still consider performing a liver biopsy? In South Korea, where the prevalence of HBV infection is high, there are quite a few cases where treatment is started based on the assumption of HCC without biopsy in such cases. I want to hear your opinion.
In our place, we also, most of the HCC are due to chronic hepatitis B, and we use the same markers. But in most of circumstances with such a big lesions showing on the CT scan, as I said, we would not proceed to a liver biopsy because of the risk of the liver biopsy and also of the potential seedlings which can be incurred by the liver biopsy itself. We have some experience about this. And especially in the case when we consider the resections, as a possibility of the management of the patients. So we don't, in most of the circumstances, we do not proceed with the liver biopsy. As I said, we will do a PET-CT scan and to see whether the uptake is compatible with hepatocellular carcinoma. Because one of the issues is whether sometimes these tumors are not a typical HCC, they might be a mixed type, which carries a different prognosis, and there will be a slight difference in management for these patients. So that's our practice. I would like to hear the other panelists of their practice in managing these cases.
Well, in general, I agree large tumors like this may have risk of bleeding. Dr. Lau is absolutely right. But in Hep B, there is a possibility. Can you go back to the image again of the CT scan? Of the CT? Yeah. Now, when you look at it, the first impression is it may be a non-cirrhotic liver. And if it is a non-cirrhotic liver, if I have to do biopsy, maybe I would do tumor and non-tumor area and then see whether there is, because there is no splenomegaly in this. The biopsy may have a risk in this because this is reaching almost the periphery. So I'm not sure biopsy would add. The characteristics of the tumor may be not so clear, whether this is HCC or it is fibrolamellar or it is something else. So biopsy is indicated, but with great caution. This is my thought. Maybe we can ask Dr. Sheena and Dr. Kanda, if anyone.
So in this case, so we will probably not perform biopsy because so we think that this is relatively typical finding of HCC. So from the radiological features, CT scan imaging. So we don't think, and he had the elevated alpha fetoprotein and PBK2 levels. So we don't think we will perform biopsy. So.
So I think that if there are very high chance of having HCC because of the risk of bleeding or seeding, so liver biopsy is not recommended for those who have no risk factors for HCC and who have who have risk factors for HCC. But in these patients have no definite risk factors, I think a liver biopsy is indicated. But I think the patients have HBV infection and their chance to have HCC is very high, then just skipping the liver biopsy may be considered. I also agree on your opinion.
So what kind of differential diagnosis did you have at that time besides HCC?
Well, maybe combined type of HCC and cholangiocarcinoma or intrahepatic cholangiocarcinoma. And it is not likely, but maybe some other tumors with liver metastasis can be considered. So the features of LRM tumors is definitely malignant, but not specific for HCC. We can think of many diagnosis, many potential diagnosis, including such tumors.
And if you perform biopsy and get some information, will those findings will change the treatment strategy? Do you think?
Yes, because maybe if the patients was diagnosed with intrahepatic cholangiocarcinoma, then maybe we have to consider this tumor is resectable or not. And if the tumors is not resectable, we may think of systemic chemotherapy, maybe GP-based chemostherapy. Or if the patients have HCC, diagnosis with HCC, we have many options for treating this large tumor. So I think that this is quite a big difference in managing the patients. And my second question is there a genetic mutation profile analysis that would aid in the diagnosis for this case?
If it is HCC, then I doubt very much there is any mutational profile that could help. But if it is not, or it's a mixed type, then might be. So in fact, I want to go back to whether you have CEA level of these patients before the biopsy. I mean, you already have a biopsy.
Yes.
Yeah,
so,
but then it's a CEA is there. So you see the CEA 99.9 and CEA is normal. So it's pretty classical. I won't do a biopsy. I mean, for these cases, it's not necessary. But since you have already done this, so I don't think there's any harm anymore to do further analysis. But for a hepatocellular carcinoma, genetic mutational profile is unfortunately still not very useful to guide our systemic therapies or other therapies because we don't have a targetable mutations for hepatocellular carcinoma.
I think I totally agree with Professor Lau. I'm sorry, I'm out of the office. Because I think the tumor is a big tumor with satellite. I think it's likely to be, if not unlikely to be metastasis. So I think it's going to be primary, and we don't know whether just liver biopsy just small tissue can you know, if you can find mixed hepatocholangiocarcinoma, that would be another issue. But it is unlikely to get the sort of small tissue and to have mixed tumor at the same time. Thank you.
So even if we perform biopsy and we can get some specimen, we are not sure whether those specimens represent the entire tumor. Maybe so the tissue may be different from place to place. So in that sense, we will not perform biopsy, and probably we will do chemotherapy for systemic therapy, as this is considered so hepatocellular carcinoma, and probably because all the elevated tumor marker levels and radiologic findings, it is very probable that this is a hepatocellular carcinoma. So we'll do systemic therapy for hepatocellular carcinoma first, and follow whether there's a response or not.
Thank you so much for your opinion. So, okay, then what would be the best treatment options for this patient? TACE or TARE, or surgical resection, or systemic chemotherapy, or any other treatment?
So how many daughter nodules, satellite nodules in this patient?
Where 3 to 4 nodules were located in left hemiliver.
Mm-hmm.
In our place, we would try the TAC to see whether there is any response. And then if it does not, or it becomes non-responsive, then we would do systemic chemotherapy. Well, it's actually systemic therapy, not systemic chemotherapy. Nowadays, we talk about systemic therapy with PD-1, PD-L1, or the Avastin, or the CTLA-4 as the systemic therapy for this patient.
Any comment? Or maybe for taste or tari in this case? So, Prof. Lau, regarding the systemic therapy, what do you prefer for this?
Well, we have two first-line systemic therapy, not chemotherapy. We can use the atezo beaver, or we can use the strike therapy with the CTLA-4 high primings followed together with PD-L1s and followed by PD-L1, the durva. So there are two registered first-line therapy. For those places where there is a resource limitations, then we can go back to use lentivimate and the others. But this is not the first choice in these patients. The tumor is big, and I can see there is vascular enhancement. There are satellite lesions. We would try the TAC first, and to see how much we can shrink the tumor to give the best benefit for the patients. And once it start to respond, we'll keep on the TAC. And if it fails to further response or it's refractory, then we'll give the systemic therapy. Systemic therapy. And we have seen patients we improved completely, and then the tumors becomes resectable, or even to reduce to a size we can give liver transplantations to have as a curative form for these patients.
So is there a role for the SBRT or radiotherapy?
Yes, that's a very good questions. That's very good questions. I think that there is a lot of potentials to use the other therapies, especially the radioembolizations. And in China, we also used a HIC therapy. That's arterial chemotherapy, the HIC. And they respond sometimes pretty well. I just have a very difficult to treat patients in complete remissions with repeated TACs and HIC, and also systemic therapy. So sometimes it happens, especially with patients with the underlying etiology being chronic hepatitis B. There are amazing results with the use of these first-line immune checkpoint inhibitors therapies, which they actually do better than the others liver cancer, which is due to different etiology.
Yeah. Other comment from other panelists?
In case that the rest of the liver is not cirrhotic, and then also the satellite in the left lobe, how about the third option for a surgical resection? This tumor occupy almost the whole right lobe and intraoperative IPA. Because the test alone maybe is not adequate in this case, because the tumor is very, very large. And in the countries where systemic therapy is not available or not affordable, is that the option for this case?
Well, my opinion is that this tumor is very, very big, and there are satellite lesions. And even if you can resect, you need, well, the basic principles behind resections is you have enough remnant livers for the patients to survive. And with such a big tumors, you have a very small left lobe seen in this patient. So detailed calculations of the liver volumes remaining is important. This is point number one. Point number two is, even if you resect, these patients usually have a very high rate of recurrence if it is just by resection itself. So I still go back to, well, TAC, this is a big tumor, but sometimes it helps to respond and to shrink the tumors a bit in those cases. And then with the add-on systemic therapy, I think it will give the best shot for the patients. And as I said, we have multiple experience with these cases with the liver tumors can be shrink to the levels we can do resections or even liver transplantations according to the up to 7 criteria we are currently adopting for as a entry as accessibility to liver transplant salvage for these type of patients.
Yeah, thank you. If there is another comment, we can proceed.
So thank you so much for active discussion. So as Professor Lau mentioned, considering the small size of the left liver and the high likelihood of post-operative recurrence, surgical resection for these patients was deemed unsuitable. So therefore, we opted for TARE as the initial treatment. And prior to TARE, the lung shunt fraction was confirmed to be 12.1%. And subsequently, we infused 5.5 gigabecquerel of Zerasphere via right hepatic artery, and a total of 250 gray of radiation was delivered to the tumor. So I think this is already discussed a little bit, but as you already know, as the tumor size increases, the liver to lung shunt fraction also increases. So if TARE was not feasible in these patients due to high liver to lung shunt fraction, what treatment option would you choose instead of TARE? And I agree that Professor Lau already mentioned that the first we may consider TACE and observing the response, and if the liver to lung shunt fraction decreases after TACE, we may reconsider TARE as an alternative option, or if there is no tumor response, we may think of systemic chemotherapy for these patients. But I want to hear other opinion from the panelists.
Frankly, there is not much choice once you have the local regional therapies becomes not feasible for these patients. I think you once have to go to systemic therapy, but in those circumstances, as I said, some of them do respond. So it's not an absolute no hope case with systemic therapy, especially now as we use the potent immune checkpoint inhibitors with atezo or the dual immune checkpoint inhibitors with the STRIKE therapy. And also one good things about these patients for systemic therapy is I think the alpha fetoprotein is not too high, and it's only in the range of 2,000 to 3,000. So in our experience, these patients sometimes respond pretty well. So especially they are hepatitis B related. So I think if TARE is not available, it's not feasible, or the TACE is not feasible, then we will give systemic therapy for these patients. And if the patients cannot afford these expensive therapies, then we might go back to the TKI, the oral therapy. But then the chance will be very low for these patients to survive, or they might have a prolongations of survival, but not much chance to go into a curative therapy for some of those patients.
So any other comment from the panelists? If no, we can proceed, Prof. Mo.
I totally agree with Professor Lau, and let me proceed. So 1 month after TARE, the internal portion of the main mass showed necrosis, but the extent of viable tumor in the peripheral portion increased, and a new 3 centimeter new mass appeared in hepatic dome. In addition, focal rupture accompanied by hemoperitoneum was observed at segment 5 and 6. So at this point, what would be the best treatment option for the patients? TACE, TARE again, surgical resection, or systemic chemotherapy? I would like to hear your opinion.
Yeah, Prof. Josh Lau. What is your comment?
Yeah, I try to give an opportunities to hear others people's opinions on this complicated case. Maybe I should let others to talk and before I make my comments.
Any comment from other panelists? Regarding the MRESIS,
Yeah, if not,
Like-
I would try TACE. Surgical resections with intraoperative RFA. I'm not sure whether these patients can tolerate such aggressive therapy. You need very good surgeons. It depends on the confidence of the surgeons and the facilities. It's not as easy operations if the patient can survive. So safer maybe in the less resourceful areas we can give embolizations with the TAC. Because sometimes with the radio embolizations they cause too much necrosis, and we have seen problems with perforations and so on. So maybe TAC in less resourceful places. If you have aggressive surgeons and very competent and a powerful team, you can consider surgical resections and more aggressive therapies with intraoperative RFA. But just relying on systemic therapy might not be too helpful because it takes time for systemic therapies to come into play, and you need a more drastic, a more aggressive approach at this point for the patients. So either transarterial chemoembolizations or surgical resections with intraoperative RFA.
I totally agree with Professor Lau. I think the first option going to be more feasible for in this case because he underwent tear, so there is no occlusions of the previous vessels. I think access to the artery is not the issue in this case.
Yeah. So the surgical resection, is it?
I think it's too late.
It's not possible.
It all depends on how good the surgeon is and how aggressive, because you already have a massive necrosis. Well, my concern is we have to think about the recurrence rate will be extremely high even if you go in and to survive the surgery itself. It's so clear that the option 3 is the most traumatic therapy for these patients. You have to go in, open it up, and resect, and it takes hours of operations. And I don't know the physical status of this patient, whether he can survive. And we have seen many problems with such aggressive therapy sometimes. So it depends on the facilities itself. If you have good surgeons, very competent, aggressive team, then maybe option 3. But usually, if they don't want to take the risk, then for the patients, option 1, and then follow with option 4, systemic therapy. And by the way, transarterial chemoembolization, TAC means chemo embolizations. It's TACE, transarterial chemoembolizations, not chemotherapy.
One more option can be use of SBRT. And if it's a possibility, I know in Korea you may have SBRT very well, and maybe in other parts. The reason is it's a very large tumor, although it is close to some vessels, but SBRT may be better. I agree with Dr. Lau that a tear may not be as effective. So my first choice would be SBRT if the surgeons are not able to handle it.
Yeah, I also totally agree with Professor Lau. So we thought that, we may consider surgical resection for this tumor, but we thought that there was very high chance of recurrence after surgical resection. So we proceeded with TACE. So 2 months after TACE, CT scan revealed an increase in size of the HCC in the right liver, along with portal vein tumor thrombus, while the HCC in the left liver remained similar in size. In addition, a 2.3 centimeter peritoneal metastatic nodule was observed in right paracolic gutter, and there was a small lung nodule suggestive of lung metastasis. And at this time, laboratory results show the decrease in albumin to 3.1, and prothrombin time decreased to 67.9%. The patient was classified as child class A6, and tumor markers were found to be alpha-fetoprotein 1034 and PIPCA to 10,132. So what would be the best treatment option for the next course of treatment? Atezolizumab, or lenvatinib, sorafenib, TACE plus EBRT, or other treatment?
Well, I think that's atezo-bevo or the strike therapy for these patients as systemic therapy. It has been shown that both new first-line therapies are superior to sorafenib, and lenvatinib is only non-inferior to sorafenib as first line. We have seen patients with complete remissions with systemic therapies in not in exactly the same scenario, but in a slightly different scenarios with metastasis outside the liver to the peritoneum, and they respond and go into remissions, complete remissions with that index lesions.
There any comment from panelists?
This is Tatsuo Kanda. I agree with you. I recommend you immune checkpoint inhibitor without anti-VEGF therapy. Because he has subcapsular hemorrhage, and so anti-VEGF accelerated hemorrhage from them, and he has extra hepatic metastasis. So I want to fast systemic therapy.
Thank you, Prof. Kanda. Prof, one more choice, please proceed.
Yeah, so we also treated patients with atezolizumab, and after 3 cycles of treatment, the size of liver tumors significantly decreased, and the peritoneal seeding nodule disappeared. And after 6 cycles, the size of the liver tumors continued to decrease further, demonstrating a partial response or a near complete response. So yeah, let's have a short discussion, and I think this is the last point. Considering the risk of bleeding in a case with HCC rupture, as Professor Kanda mentioned, is the use of atezolizumab safe in this situation? And is there any evidence that atezolizumab may increase the risk of bleeding recurrence in a case with HCC rupture? And how is the risk of rebleeding in a case with HCC rupture and compared between atezolizumab versus other TKIs such as lenvatinib, sorafenib, or alternative therapies such as TACE?
Well, I think Professor Kanda makes a very good point. But then have you ever considered using strike therapy with the CTLA-4 and the PD-L1 instead of atezo-bevo in these patients?
Yeah, that's a very good point. But at that time, STRIDE protocol was not available in Korea.
Oh, I see.
Yes.
Okay. Yeah, STRIDE is only become available last 2022.
Mhm.
Is it registered in South Korea?
Well, I think so, yeah, but I'm not sure.
Very late. Yeah,
Mhm.
because 2022 October they get it done in FDA, and then the European followed by the Japanese colleagues.
Mm.
Okay. Any comments from our Japanese colleagues on this case? Would you use STRIDE in this case instead of atezo-beaver if it is available? Professor Sheena or Professor Kanda?
We prefer atezolizumab plus bevacizumab because the iduronate therapy is relatively severe in terms of adverse events. So this patient relatively young, but is the patient liver function slightly deteriorated. So maybe we prefer atezolizumab and bevacizumab in this setting.
I might have missed whether this patient had varices.
But there was no varices for these
No.
patients.
Yeah. Not then I think atezo-beva is a very good choice. Only thing is how long can you manage him? And also, this patient has some cytokeratin positive. So one has to exclude whether there was some possibility of hepatocholangio. If that is not there,
Actually, there is no data that atezolizumab can increase the risk of bleeding in such situations. For my experience, I have similar 3 to 4 cases, and those with ACC rupture and who started atezolizumab, there was actually no rebleeding from the tumor for all or 4 cases. And I think the tumor response by atezolizumab treatment is good. Then the rebleeding risk also decreases. Well, we have to collect more data on this issue, whether atezolizumab can increase the risk of bleeding from those experienced with HC rupture.
Maybe any experience with in regards of the bleeding in experience from the panelists?
With the bleeding in such instances, I don't think it is as severe as it is said in those patients with varices, and sometimes even in those patients with varices, we give atezo-beaver with a good safety record. It's said, and it is indicated in many of the studies, and is in the drug indications and the contraindications. But then, in the real life, we have our versions of anti-VEGF in China, and we have quite a lot of experience in using that versions. And also, we also have atezo-beaver from Roche. But then it's not as severe, even in those patients with varices. And in this case, with a rupture of HCC, we don't have a lot, a systematic review, but we do use this type of therapy. But having said that, I think if the STRIDE therapies is available, I think we should go for the STRIDE first. With the CTLA-4 and PD-L1, rather than going to the atezo-beaver, as in this case. But anyway, well, it shows in this case the patients have a tumor, the shrinkage, and the metastasis is gone. So it's good for the patients. It's a very interesting case. There is no rupture too. So it has been used. So that's actually going against what we are worried about. We have been worrying about. And this is also some of the clinical experience we have gathered.
Yeah, I totally agree with you. So if I have to choose between the STRIDE protocol and atezolizumab in this case, I think I am for STRIDE protocol because of the risk of the bleeding. But at that time, we have no options other than atezolizumab. So we just
right.
Yeah,
exactly. Now we have an options, and hopefully we have more research and bring more clinical medicines into the scenario so that we have options.
Is this the end of the presentation, Professor Wong?
So yeah, to summarize the case, this is patients with advanced HCC demonstrating LRM features confirmed by tissue biopsy. And despite one session of tear and one session of TACE, intrahepatic tumor progression and peritoneal seeding occurred, leading to the initiation of atezolizumab treatment, which has since shown a very good tumor response with ongoing treatment maintenance. And this red solid line represents the trends in alpha-fetoprotein levels, which dropped dramatically after initiation of atezolizumab. And this is the take-home message from the case. So thank you very much for your attention. And in addition to the APASL 2024 held in Kyoto, I would like to promote the Liver Week hosted by the Korean Association for the Study of the Liver, scheduled to take place from June 27th to 29th in Seoul this year. We kindly request your attendance. Thank you very much.
Thank you very much.
Thank you very much.
Choi, for the very interesting case. So because we have to proceed to the next session. So the next session will be deliver the topic genomic landscape in HCC by Professor Jean Charles Nault. So Professor Jean Charles Nault is from the Cordeliers Research Center, Sorbonne University, in some University of Paris, France. And she worked in liver unit, Avicenna Hospital, Paris Saint-Denis University Hospital, Public Assistant Hospital of Paris, Bobigny, France. So, please.
Thank you for the invitation. You hear me? It's okay?
Yeah.
So I will share my my screen. Okay. So do you see the slide? It's okay?
Yes, very good.
Perfect. So so I would like to thank this APASL for this invitation, and also Chief Sarin as usual. And so I will talk about the genomic landscape of HCC and personalized treatment. So this is my conflict of interest. So first, I will talk about the molecular pathogenesis of hepatocellular carcinoma, and after about precision medicine in HCC. So we are a little bit far away from other cancer for precision medicine or from cholangiocarcinoma, but I will give you some clue how we could translate maybe in the future what we know on genomic of hepatocellular carcinoma. So molecular pathogenesis of HCC. So as you know, there is an accumulation of mutation in the DNA of hepatocyte that gives rise to malignant transformation. It's due to all of genetic predisposition, environmental exposure, oncogenic viruses like HBV, and after there is a role of accumulation of mutation and modification of transcriptomic landscape that promote tumor progression. So I will discuss all these points. What are the current genetic landscape of HCC, the mechanism of malignant transformation, and tumor progression in this part. So if you take an HCC, you have around 40 to 60 somatic genetic alteration in coding sequence per tumor if you do whole exome sequencing. Most of the mutation are driver mutation, 2 to 6 per tumors that are important functional mutation. involve signaling pathway important in carcinogenesis. And most of the mutations are passenger mutations. So when you analyze the genome of HCC, first point, you have to identify what is driver that is important for carcinogenesis and that you want to target maybe, and identify passenger mutations that are not important for this patient. So this is the main genetic alteration that are currently mutated in hepatocellular carcinoma, the main signaling pathway. So I will talk briefly about this mutation. There is mutation in telomere maintenance pathway with, we will see mutation in the TER promoter as the most frequent genetic alteration in HCC. Well-known mutation in cell cycle genes, and the most important one is TP53, that is a tumor suppressor gene. Mutation in F2L2 and Wnt beta-catenin pathway that are oncogenic pathway, and beta-catenin are mutated in 10 to 40% of HCC, and mutation in epigenetic driver genes like ARID1A, histone methyltransferase. And there is few mutation in AKT-mTOR and MAP kinase pathway, such as FGF19 amplification on the right, P10 deletion, TSA1 genetic alteration. I will come back at the end. So, and interestingly, these mutations are associated with risk factors. So if you deal, like in Asia, mostly with HBV-related HCC, you will have a different genetic landscape in terms of percentage of gene mutated compared to alcohol-related HCC, for example. And I just want to give you some examples that we have published in Nature Genetics in the lab. For example, HBV-related HCC are more frequently mutated for TP53 compared to other etiology. In contrast, alcohol-related HCC are more frequently mutated in TER promoter, in ARID1A and beta-catenin, CTNNB1, and HCC with unknown etiology. There is some case in France, in normal liver, are rarely mutated in TERT and are activation of JAK-STAT pathway. So there is an enrichment of mutation according to the risk factors. So it's important to take into account when you analyze a series of HCC worldwide. And there is an association of this mutation with transcriptomic classification, the risk factor and prognosis, and there is different subgroup of HCC based on the genetic alteration. And here I will just give you some example of the different subgroup of HCC, the relation with genetic alteration, clinical feature. So here it's a transcriptomic classification in 6 subgroups that are associated with chromosomal stability and instability. Chromosomal instability is loss and gain of chromosome, and with clinical feature. And for example, there is a subgroup of HCC that harbored stem cell features. So it is a re-expression of genes that are currently expressed in fetal liver. So for example, expression of EGF2, insulin growth factor 2, that are usually expressed in fetal liver, are re-expressed in this subgroup of tumors, of CK19, EpCAM, that are usually not expressed in mature hepatocytes, but here that are expressed in this subgroup. And this subgroup of HCC with stem cell feature are more frequently HBV-related, female, high alpha-fetoprotein level, chromosomal instability, P53 mutation. And there is another subgroup that are associated with BAP1 mutation, and it's interesting in terms of presentation at histology. I don't know if there is pathologist here, but this HCC that have stem cell features have also fibrolamellar features. It's not a true fibrolamellar like the young HCC fibrolamellar features. It's oldest patient, but the pathologist said it's okay, the patient at 50 years old, but at histology it looks like a fibrolamellar carcinoma. But the age is not so good because usually fibrolamellar carcinoma, usually one are younger. And here it is HCC with BAP1 mutation. And this HCC of BAP1 mutation have fibrolamellar features. So there is what we call the genotype-phenotype classification. Another subgroup of hepatocellular carcinoma, I will come back after, are associated with FGF19 amplification, TC1 and 2 mutation, and at histology are characterized by what Julien Calderaro or pathologists called the macrotrabecular massive subtype that is easily identified at biopsy or at liver resection. I will come back after, and are associated with poor prognosis. So when you have this subtype macrotrabecular massive HCC, it's a specific genetic subtype of HCC with dysregulation of cell cycle genes, amplification of GF19, TSC1 mutation, and poor prognosis. There is a subgroup of HCC that are close to mature hepatocyte, that are well differentiated, sometimes JAK-STAT activation, and including a small subgroup of steatotic hepatic HCC that are developed in NASH patients. And finally, the last subgroup of hepatocellular carcinoma of the genotype-phenotype correlation are HCC with beta-catenin mutation that are chromosomal stability. It is exclusive, beta-catenin mutation are exclusive from TP53 mutation, and these HCC have cholestasis. So sometimes you can see a green HCC, and green HCC is related to cholestasis and related to beta-catenin mutation, and you can identify by sequencing or glutamine synthase expression this subtype of HCC. So it seems that there is a heterogeneity in terms of classification, heterogeneity in terms of genetic alteration, histology, clinical features, prognosis, and it's why precision medicine is so difficult to do in hepatocellular carcinoma, because there is a large number of different molecular subtypes of HCC that are difficult to identify. But we know the main genetic driver, and we know that there is a high heterogeneity. So the first point is when you discuss how HCC occurs, it's how malignant transformation occurs, and specifically in cirrhotic patients, because cirrhosis is all damage senescence to liver, and how this cirrhotic hepatocyte goes to malignant transformation. And you have to know that there is telomere attrition on cirrhosis. Telomere is short DNA repeated sequence at the end of the chromosome. And when you have DNA replications, telomere decrease in size. And when you see a cirrhotic liver, there is very short telomere due to cirrhosis, due to aging, and there is no telomerase activity, that is an enzyme that produces telomere in this patient. So you have old liver, short telomere, and to have proliferation, you need to produce telomere to reactivate telomerase. And it's what happened in most of hepatocellular carcinoma. 95% of hepatocellular carcinoma have reactivation of the enzyme, the telomerase, that produce telomere at the end of the chromosome. And it's important for proliferation. And the most frequent genetic alteration that are identified in this HCC are related to mutation of the promoter of telomerase itself. 30 to 60% of the HCC have mutation in this TER promoter. After, you can have viral insertion, HBV, for example, in the promoter, amplification of the genes, so you increase the number of the copy of DNA of these genes, or translocation between two genes, including telomerase. So all HCC almost all of HCC have telomerase reactivation at the very early step of malignant transformation due to different mechanisms that you can see here. So, and you can see here the percentage of TER promoter mutation in early HCC, less than 2 centimeters, very well differentiated, 60% of mutation. And you can see we identified also in pre-malignant lesion. You know, there is sometimes pre-malignant lesion in cirrhotic liver, low-grade dysplastic nodules and high-grade dysplastic nodules. And we identified mutation of TER promoter in this pre-malignant lesion, and probably that promotes malignant transformation in the future. And it's the only genetic alteration identified in pre-malignant lesion on cirrhosis. It's TER promoter mutation. So it's very important mechanism at the early step. After you have accumulation of mutation in other driver genes, TP53, beta-catenin, and so on, and you need accumulation of mutation to have tumor progression, metastasis, portal vein thrombosis. And you can see here that when you analyze advanced hepatocellular carcinoma, BCLC-C, with metastasis or portal vein thrombosis, you have accumulation of specific aggressive transcriptomic subgroup of HCC, and specifically the G3 macrotrabecular massive subtype with FGF19 amplification, TSC1, TSC2 mutation that are increase in number when you have advanced hepatocellular carcinoma. And it's so logical, but because even in small tumors, this subgroup is associated with poor prognosis. So with advanced HCC, we have more frequently this subtype in metastatic patient or portal vein thrombosis patients. And also, you have increased mutation in P53 in advanced cases. You can see that tau promoter mutation or beta-catenin are almost stable according to BCLC stages, but you have double the frequency of TP53 mutation double in BCLC patients. We don't know if it is because P53 mutation are a poor prognosis baseline and you have metastasis, or if you have accumulation of P53 mutation when you have metastasis. So if it is a primary mechanism of a secondary mechanism that occur during metastasis or portal vein thrombosis. And you have also performed full whole exome sequencing in advanced hepatocellular carcinoma in tumor biopsy. So it's highly possible to do whole exome sequencing and whole genome sequencing on tumor biopsy. You identify all the classical HCC driver genes, and you have an enrichment of P53, but also of mutation in retinoblastoma 1, that is a gene that is associated with also a poor prognosis, and also with SF3B1 genes. So you have enrichment of some genes in aggressive cases. And it's look like that when you have first, telomerase reactivation, Manningham transformation. Second point, acquisition of genomic diversity, heterogeneity. And after, distribution of the two key pathway controlling the cell cycle, P53, but also RB1 here, with mutation of RB1. So it's why you have aggressive tumor at the end. It's dysregulation of cell cycle genes by mutation and transcriptomic dysregulation. Okay, the second point, I will discuss precision medicine. So it's what we know in terms of molecular pathogenesis. Now we want to know if can we use it in clinical practice. So there is different points that I want to address. The first point is the differential diagnosis and classification, the genotype-phenotype classification. So when you have a atypical nodule on cirrhosis and ET imaging, maybe it's low-grade dysplasia nodules, maybe your early HCC, you don't know. It's not typical. You can have tumor biopsy, and sometimes it's difficult to the pathology say, I don't know, early HCC, premalignant nodules. Do we need to treat this patient? And sometimes what we do in my clinical practice is to do the tau promoter mutation on the biopsy. If there is a differential diagnosis between early HCC and low-grade, high-grade dysplasia nodules, if we identify this tau promoter mutation, it's probably that these tumors are going to transformation to HCC or is already an HCC, and we go to treatment. If you don't find the mutation, you can discuss treatment or follow-up, I think. The second point, sometimes you have difficult diagnosis. You have traditional fibrolamellar carcinoma, very rare. Young patient, no cirrhosis, classical genetic fusion DNGAB1 PRKCA in 100% of the patient. And it's important to know that there is a other subgroup of HCC of older patients in non-fibrotic liver with a histological feature close to fibrolamellar carcinoma. It's 5% of HCC, but it's not related to the classical fusion. And it's not a young patient, it's related to BAP1 mutation. So it's not the same genetic alteration. It's just, there is a clinical phenotype close to old patient with HCC. So it's not the same tumors. So it's for diagnosis. For prognosis, what we have is we know that the macrotrabecular massive HCC that are specific molecular feature, dysregulation of cell cycle gene, neogenesis, FGF19 amplification, TSC1 mutation, are easily identified at tumor biopsy or in a surgical sample, are associated with very poor prognosis. The last one I've seen in my clinical practice have a brain metastasis. So, brain metastasis in HCC is very rare, and it was a macrotrabecular massive HCC, very aggressive with brain metastasis. And you can see here that it predicts survival after resection or ablation. So very aggressive. I will skip that. And just to discuss a little bit more artificial intelligence, because we know that artificial intelligence is currently a very hot topic. And here you can see it's a series of patients treated by liver resection. And this is work by my friend Julien Calderero in France, who use a training cohort to train artificial intelligence, deep neural analysis, and after applied in a validation cohort to predict survival. It was only histological slide, and you can see that based only on artificial intelligence, you could predict survival on a HE slide. So it's very powerful. It's only in surgical sample and need validation on tumor biopsy, but I think it's one of the main tool that we will have in the future with artificial intelligence. And in some cancer, for example, colorectal cancer, it's artificial intelligence could predict the molecular subtype on slide. So, for example, microsatellite unstable colorectal cancer could be predicted using artificial intelligence on slide. So, for the last 5 minutes, I will discuss prediction of response of treatment and new therapeutic targets. So, there is 3 points. The identification of predictive biomarker of validated systemic treatment, targeting rare genetic alteration, and treating the undruggable genes. So the first one is identification of predictive biomarker of validated systemic treatment. So this is the current landscape of systemic treatment in advanced hepatocellular carcinoma. First line, atezobev or durvalumab, and second line, we use mostly tyrosine kinase inhibitors. Even it was not tested after atezobev or durvalumab, because if you have no clinical trial, we have only this treatment. So the first question was the predictive of sensitivity or resistance to immunotherapy. There is preliminary data that suggests that beta-catenin mutation were associated with resistance to immunotherapy. On the left part, based on a mouse preclinical model, because when you have a HCC with P53 mutation, you have response to immunotherapy with the best survival. And in contrast, when you have a beta-catenin HCC in this mice model, you have resistance on the lower part, resistance to immunotherapy. And there is some retrospective data, so small number of patients, suggesting that you have resistance to immunotherapy when you are with beta-catenin activation, and in comparison, with beta-catenin activation wasn't associated with progression-free survival in patients treated by sorafenib. So it was a question mark, but mice are not men, and retrospective sometimes studies could be misleading, and it is an interesting study from Andrews based on the molecular analysis of the phase 1 and phase 3 clinical trial of atezobeva. So first, they reanalyzed the beta-catenin mutation, and what they identified, it's not that when beta-catenin was mutation was predictive for resistance of atezobeva, but maybe beta-catenin mutation was associated with better survival on sorafenib, because you can see beta-catenin wild type or mutated, you have the same survival in atezobeva arm, but a better survival in sorafenib arm. So maybe it's not related to resistance to immunotherapy, but maybe a better response to sorafenib. And they identified molecular signature related to immune infiltrate, predictive of high rate of radiological response, high expression of T effector cells and intratumoral CD8 T cell, and also of aggressive tumors with a high progression in atezobev, with a high T-reg to effector T cell ratio and expression of co-fetal genes, GLP-3 alpha fetal, but it was only a small subset of the whole sample that have been analyzed, so it's only preliminary. So currently, you have tyrosine kinase inhibitor, some publication about biomarker, but question mark about the robustness. Same for immunotherapy, beta-catenin mutation, PD-L1 immunohistochemistry is not good. So it's still a question mark. No strong, robust biomarker useful in clinical practice. And finally, the only biomarker that have been validated in clinical practice is serum alpha-fetoprotein to predict patient who will be treated by ramucirumab anti-VEGFR antibody, because it was the biomarker for the selection in the WITCH-2 clinical trial. So alpha-fetoprotein discovered 50 years ago and is still the only biomarker potentially used to select patients in clinical practice. So next step, we can target rare genetic alteration. So it is the next step. There is a bad news. Most of the genetic alteration frequently observed in hepatocellular carcinoma are not druggable. So it's not good. You cannot drug beta-catenin, P53, TERT, and so on. And you have only a small subset of mutation that could be treated by targeted therapy, maybe with a low frequency, less than 5% of mutation. So maximum, if you pull all together the rare genetic alteration, maybe 20% of HCC could be treated by a targeted therapy, but it's a small number. And I just, for example, there is amplification of FGF19 that are associated with a poor prognosis. There is a phase 2 showing that there is oral FGFR4 inhibitor with response only in HCC with positive FGF19 and 0% of response in HCC negative for FGF19, but it's only a small percentage of response. And after, also they developed patients who respond to FGF19, FGFR4 inhibitor, develop secondary mutation after partial response that explain tumor progression, mutation in FGFR4 that are not present at the beginning, that developed after. And there is also other cases that show that genetic alteration, rare genetic alteration could be treated by targeted therapy. For example, it's in my clinic, I treat in phase 2 clinical trial a patient with MET inhibitor, complete response during more than 1 year, and this patient have a small MET amplification. It's not frequent, 2 to 3% of HCC, and it's why this patient have a complete response during 1 year to focal amplification of MET due to the use of tepotinib MET inhibitor. And now we used genomic to identify this rare genetic alteration after progression under atezolizumab. We perform whole genome sequencing, whole exome RNA-seq in France after progression under atezolizumab. It's the first 20 patients here, and I just show you 1 or 2 examples for the before closing my talk. It's patients with HCC progressive after atezolizumab and sorafenib. We identified a TSC2 inactivating biallelic mutation. When you have this mutation, you have activation of the mTOR pathway, and we treat this patient with a mTOR inhibitor, that is everolimus, and you can see complete response after everolimus, normalization of alpha-fetoprotein, complete response at MRECIST, and now it is 10 months of complete response under everolimus. Another example is hepatocholangiocarcinoma, sorafenib, atezolizumab, bevacizumab. We sequence this tumor and we identify the CDK4 amplification. We treat this patient with a CDK4, CDK6 inhibitor palbociclib, and we have a partial response, decrease of alpha-fetoprotein, and 60 months of partial response under palbociclib. Well tolerated. And so maybe in the future, we want to treat the undruggable genes. It's my last slide. And you know that beta-catenin mutation are mutated in around 40% of hepatocellular carcinoma. It's currently not druggable. It's a hotspot mutation, highly frequently mutated oncogene. But maybe in the future, if you find a beta-catenin inhibitor, it will work. And remember that KRAS mutation were previously considered as are undruggable, and now there is KRAS specific mutation of KRAS inhibitor that are used in lung cancer. So maybe it could work in the future for hepatocellular carcinoma. And so to conclude, genomic of HCC is closely related with risk factor histology and clinical features. Most of beta-catenin, TERT, and TP53 are not druggable. There is rare mutation that maybe could be druggable, but it's only 2-3% of HCC that have this rare mutation. And we need more basic knowledge and specifically more biopsy in future clinical trial to understand the molecular biology and the, how patients are resist to systemic treatment or are sensitive to systemic treatment. And thank you for your attention. If you have any question, I'm open to question.
Thank you, Dr. Jean Charles, for very educative lecture. And now house is open for any question. If any question from panelists.
Hello, this is Dr. Omata from Japan. Nice to hear the wonderful talks. And maybe you may remember that the first original paper about fibrolamellar carcinoma was 1980, 43 years back, by John Craig, Hugh Edmondson, Bob Peters, and Masao Omata, myself. So after 43 years.
Congratulations. Congratulations.
Nice to see you in India. Wonderful. Yeah, wonderful talk too. And the question you raised, maybe the molecular biological test or the diagnosis can be helpful for the fibrolamellar, and it's wonderful. But also there is a report in Science 2017 about the fusion transcripts in the fibrolamellar carcinoma. And then, you know, I was trained as a pathologist, so that's why we published a paper together. But since then, I saw so many cases not exactly diagnosed, correctly diagnosed as the fibrolamellar carcinoma, especially in Japan. So in that case, I think these diagnostics must be very, very important because very unique clinical pathological features they have. So in that context, did you compare the fusion data with your results? Because that's published in the transcripts, and then very high, 100%. I think that's 17 cases or something.
Yeah. So you have a comment. It's a very good question and very important because it's rare. It's difficult to diagnose for pathologies that are not trained. And we search for the fusion in all the fibrolamellar carcinoma that we have, 20 in France, and we found the fusion in all the fibrolamellar carcinoma, in all the patients. So we validate this result. But for true fibrolamellar carcinoma of the young, sometimes there is a fibrocarcinoma of old patients, 60 years old, and that are not, it's not fibrolamellar carcinoma, it's HCC with fibrosis. So in true fibrolamellar carcinoma, the fusion is a very good diagnostic test if there is some doubt.
Right. Unfortunately, they do not have, the fusion protein does not have the enzyme activation, so cannot be a target of the treatment, but can be a target of the diagnosis.
Yeah, yes. I agree. And I think they want to develop vaccination against these fusion genes, but I don't know if it's work. But I agree there is no treatment dedicated to this fusion. I agree.
One last question. When we check the multiple cancer nodules, driver sometimes changes. In other words, you are saying this case is such and such, but they often have multiple nodules occurrence. So one having the Wnt beta catenin signaling pathway, one has a TP53 pathway. So it's a very complex, not single drivers. They changes. So maybe that's more difficulty to define what the type of hepatocellular carcinoma by molecular basis. How do you think?
I fully agree. And there is, when you have multiple nodules, there is tumor heterogeneity. So some nodules sometimes have multifocal carcinogenesis independent. So some nodules, you have completely different molecular features because it's different HCC. And sometimes you have metastatic nodules and the same mutation in common, but some additional mutation due to metastasis. So I fully agree, and specifically in patients with treated by liver transplantation, because sometimes there is 3, 4, 5 nodules, and when we analyze, in half of the cases, you find nodules with different mutation in independent multifocal carcinogenesis, and in other cases, 50% of the cases, metastasis with the same mutation because it is a metastasis of the same tumor cells, and sometimes new mutation that occurs during metastasis. So it's more difficult than we think. I fully agree.
Yeah. I'm very happy to hear talk. Very comprehensive. Congratulations. See you in Kyoto.
Thank
I
you.
hope. All right, thank you.
Thank you.
Thank you.
Thank you, Dr. Jain. In interest of time, now I want to invite next speaker, Dr. Sanjeev K. Kalwa, who is the Chief Intervention Radiologist at MGM Hospital, Harvard University, USA, and he will be speak on newer diagnostic modalities for HCC. Dr. Sanjeev, please.
Thank Yashwant for the introduction. I appreciate the invitation and it's a privilege for me to speak at this course. Let me share my slides. I hope you can see my slides.
Yes,
Yeah,
sir.
it is.
Fine.
Thank you. So I'll be talking about newer diagnostic modalities for hepatocellular carcinoma diagnosis and treatment assessment. So the goal is to review the current surveillance and imaging diagnosis of HCC, and then discuss the new imaging modalities, especially in treatment response assessment. So we all know surveillance is performed in patients who have higher risk for developing cancer. Those are patients who have cirrhosis or chronic liver disease from viral hepatitis or alcoholic cirrhosis. In the US, usually patients get every 6 months ultrasound imaging of the liver. And then if the lesion is identified, then they go for further evaluation. So it has been shown that ultrasound is reasonably sensitive in picking up lesions in liver, and early diagnosis of the lesions by screening methodology would improve survival by at least 30 to 40%, both in early stage and late stage. So any lesion that is identified in ultrasound would require further evaluation. If the lesion measures less than 1 centimeter, they require further follow-up in 3 to 6 months. But if the lesion is more than 1 centimeter, they require further imaging with MRI or CT to make a diagnosis of HCC. So once a lesion is more than 1 centimeter, the patient usually undergoes CT or MRI imaging. On these imaging studies, you are looking for 2 things: enhancement in the arterial phase and washout in the portal venous phase. If both these are present and the lesion is more than 1 centimeter, it is diagnostic of HCC. If it does not fit these criteria, then either you can do biopsy or you can follow up in 3 to 4 months' time to see whether the lesion grows, and then again go back to MRI scan or do a consider biopsy. So we can also use contrast-enhanced ultrasound instead of CT and MRI to detect arterial enhancement and washout. As you could see in these pictures, there is no lesion, no identification here. As you inject contrast-enhanced ultrasound, you can see as the arterial bubbles come through, you can see enhancement of the lesion well identified on the 28 seconds time. At the late phase, you can see washout and small peripheral capsular enhancement, which is normal parenchyma around this enhancing at the same time. So arterial enhancement and washout and more than 1 centimeter in size are characteristic of HCC. And contrast-enhanced ultrasound is as sensitive and specific compared to gadolinium-enhanced MRI. However, the main limitations of contrast-enhanced ultrasound is that first, you must have identified the lesion ultrasound. If you have not identified the lesion, it is very difficult to employ contrast-enhanced ultrasound. Second, you can only image one lesion at a time with the contrast ultrasound. So for each lesion you image an ultrasound, you have to do multiple injections of contrast enhancement to identify the characteristic arterial enhancement and portal venous washout phases on contrast enhanced ultrasound. The main limitations are it is very difficult to identify lesions in patients who are very obese, and it is entirely operator dependent in identifying and characterizing the lesions. It is also very useful in assessing treatment response immediately during ablation procedures. For example, a patient for HCC in the right lobe of the liver, patient had contrast allergy to ionomer contrast material. So we did not want to inject any contrast enhancement during the CT ablation procedures. Then we did the contrast enhanced ultrasound. It's a characteristic enhancement of the lesion on contrast enhanced ultrasound pre-ablation. And we performed ablation after dissecting the area from the colon. And this is the area of the lesion that is ablated, three-dimensional image demonstrating the lesion, the probe, and the body. And following ablation, you can see hyperechoic region in the ablation zone. The contrast enhanced ultrasound showed a complete response where there is no more enhancement of the lesion. Normal hyperemia around the lesion is identified, but the lesion itself is completely ablated with this ablation procedure. So contrast enhanced ultrasound is a good adjunct to assess immediate response to ablation and also identifying the lesion very well if it's not well seen with a grayscale ultrasound imaging. On CT, the identifying imaging features are the same, where there's a contrast and enhancement in the arterial phase. This is a very nice arterial enhancement in the right arterial phase. You can see it as well enhancing. And the lesion shows good enhancement of the lesion. And the portal venous phase, you can see washout of the lesion. Washout refers to lower enhancement of the lesion compared to the rest of the liver. And there's a peripheral rim-like capsule that is well identified. So, and lesion measures more than 1 centimeters. All these are characteristics of hepatocellular carcinoma. Sometimes you may also identify the mosaic patterns of perfusion. Again, the same arterial enhancement may not be uniform, but mosaic pattern, which is different and indicates that tumor is not necrotic. These all enhancing areas are live tumors. It's not a necrotic tumor. And MRI also identifies the same features: arterial enhancement, portal venous washout, and the capsule or peripheral delayed air phase. So again, the lesion measures more than 1 centimeters. Based on the imaging characteristics, LIRADS refers to Liver Imaging Report Data System, which identifies particular patterns of enhancement on imaging studies and categorizes the lesion as different criteria, LR1, 2, 3, 4, 5, to make it standardized across the world so that people can report similarly based on the characteristic features of the lesions. It's important to note that LIRAD applies only to patients who are cirrhotic or who have chronic liver disease, either because of chronic hepatitis C, or personal history of hepatocellular carcinoma, including those who have received liver transplantation. And it is not applicable to patients who are younger than 18 years of age, and patients have vascular causes of cirrhosis because they tend to have more of a hepatic adenomatous tissues, which can arterially enhance and contribute to false diagnosis of HCC by applying LIRADS classification. So the most important thing is a lesion that is measuring more than 10 millimeters and have arterial enhancement and portal venous washout. If you have these three features, then it is hepatocellular carcinoma. Rest of things are either LR3, LR4. LR4 is diagnosed when there is portal venous washout or if the lesion is more than 10 millimeters. But LR3 is considered when there is no washout and it is less than 20 millimeters. So it is important to identify that even LR3 lesions can be hepatocellular carcinoma in 30% of the times, whereas LR4 lesions tend to have HCC in 70% of the times, whereas LR5 probably 95% of the time they're HCCs. So when we make LR5 diagnosis, you don't really need to make biopsy as a requirement to make a diagnosis. But LR4, we recommend biopsy in those patients because more than 70% of these lesions tend to be HCCs, and we tend to want to diagnose them early enough that we do biopsy. For LR3 lesions, you could technically wait in 3 months and re-image them. If the lesion is stable, you can observe it. The lesion is progressing in size, measuring more than 1 centimeter at the time, or if the new characteristics has come, this peripheral washout, more arterial enhancement, then it moves from LR3 to LR4, then you can consider doing a biopsy instead of watching wait for. Or you can make diagnosis of LR5 if all the features are present. So this is how we follow based on the same recommendation by this author. LR1, LR2, we don't do any biopsies, they just go back to imaging. Surveillance. LR3, we tend to do short-term imaging at 3 months' time. LR4, we tend to prefer to biopsy in these lesions. LR5, we generally don't do biopsies unless they're part of a study or we're looking for genomic analysis in those patients. In addition to characteristic arterial enhancement and portal venous washout, as you could see here, arterial enhancement, portal venous washout, and peripheral rim-like capsule, one can also employ what is called diffusion MRI in diagnosing these lesions. Highly cellular tumors restrict water molecular diffusion in the tissues, causing enhancement and diffusion weighted imaging so that it appear as high intensity signal on diffusion MRI or in the heavily T2-weighted imaging, the lesions can appear as bright signal. Correspondingly, the apparent diffusion coefficient decreases to respond to this diffusion changes. So why is this important? If the lesion is not very clearly visible in arterial enhancement, if it's diffusion positive, one can make up for this possible diagnosis of HCC and make further efforts to biopsy those lesions. And it's also helpful in assessing response after treatment. For example, there's a patient who has a large HCC in segment 4 and a chronic swelling partly into the right lobe, and this is T2 bright and diffusion. It's extremely abundant diffusion. It is arterial enhancing, and there is a washout, and there is a capsule. So this patient underwent a Y-9 radioembolization. At 2 months period of time, you can see complete response with no more enhancement or bright signal on diffusion weighted imaging or on T2 and complete necrosis on contrast enhanced imaging. So early changes in response may be observed in diffusion weighted imaging. So one could use that as a prognostic significance by assessing diffusion changes post-treatment. You can also do ADC maps or portal venous enhancements. This paper early showed that a very quick change in the ADC maps, at least 25% decrease in ADC, or 65% reduction in the portal venous phase enhancement following TACE represent a good response in these veins. Not only that it will assess the response, it can categorize and allows us to infer the survival patterns. If you find both are present, they respond quite well. The survival is quite high. If at least one of them are positive, at least they have reasonable amount of survival. You can see around 30 months to 35 months survival. If the patients do not have either change in ADC or in the portal enhancement, then they will not respond. They don't live that long, or it's less than 10 to 15 months period of time. So you can use early markers of response to assess survival in these patients and probably change the therapy if they do not show increase in ADC or decrease in portal venous phase enhancement. Another thing in MRI is one could utilize hepatobiliary enhancement characteristic of gadoxalic acid to assess presence of a lesion. When you use a gadolinium enhanced imaging, the lesion may show enhancement in the arterial phase and may not show any washout. Those are considered LR3s. However, you cannot differentiate them from a pseudo enhancement that is present in its perfusion abnormalities. So to assess a lesion is present versus it is pseudo enhancement, one could employ this gadoxalic acid or hepatobiliary contrast enhanced MRI scans, where you could see in the same patient has 2 lesions. One of the lesions is a perfusion defect. Other lesion demonstrate hypointensity on the liver-specific contrast MRI scans, and this is a true lesion and probably worth following or biopsying the lesion to assess for hepatocellular carcinoma. So the advantage of hepatobiliary contrast enhanced MRI is to differentiate pseudo lesions from true lesions in the terms that if they have enhancement in the arterial phase and no washout in the portal venous phase. So it also allows us to identify more lesions than can be identified in the regular gadolinium enhanced MRI scans. So you can also combine arterial phase enhancement and liver specific contrast enhanced MRI and also diffusion to assess for small lesions, as in this case, the arterial enhancement is very poorly identified in this case, but is better appreciated on the gadoxalic acid enhanced MRI scan. On diffusion MRI, the same lesion shows restricted diffusion consistent with pathological lesion here, which probably worth doing biopsy in this case. Coming to CT, in addition to regular diagnostic CT, where you do arterial phase, portal phase, and delayed phase CT to diagnose hepatocellular carcinoma, one could use a perfusion CT where more scans are obtained at a particular area of the body at a defined time intervals, more rapid than what you traditionally use regular CT scan. Instead of using just arterial phase, you scan this patient at a much more frequent interval, maybe every 10 seconds, at 15 seconds, to see how the changes in the arterial enhancement of the lesion in the tumor versus the normal liver, to assess the perfusion parameters of the lesion, and which identifies the lesion much more avidly than with just single phase or 2-phase, 3-phase CT scans. In addition to that, perfusion CT is very helpful in assessing the response angiogenic treatment. As you can see in this particular study, pre-Avastin therapy here, the blood flow to the tumor is much higher, 82 ml per 100 grams of the tissue per minute, and enhancement is quite avid. You can see the tumor is very well enhancing, whereas 2 weeks post bevacizumab treatment, perfusion demonstrates significant reduction in the blood flow and no more enhancement of the lesion. So early assessment of response to angiogenic therapy can be assessed with perfusion CT. In areas where you cannot obtain perfusion CT to limitations of the scanner or the contrast dose or because of the radiation dose to the body, one can use arterial enhancement fraction, which just slightly gives a similar picture of the perfusion, but it doesn't provide all the parameters of perfusion, but allows you to pick up the lesion much more clearly by enhancing arterial phase perfusion with a color-coded pattern and to diagnosis of the lesion. It doesn't help you to assess all the parameters, but it helps to identify the lesion much more clearly, identify the arterial enhancement to the color coding of the map. Similar to the CT, one can also use diffusion-weighted, dynamic contrast-enhanced MRI to assess the perfusion and permeability of the tumors. Here, you can see the arterial input function is iota, and the tumor enhancement is plotted over a period of time, over 4 minutes time. This is the tumor enhancement, this is the normal liver enhancement. One can use single input model where the only arterial phase is input, or you can put dual input model where both the arterial input and the portal venous input is included into the calculations, and it allows you to identify the arterial enhancement of the tumor and the portal venous washout of the tumor. And so you can show blood flow, blood volume, and permeability of the tumor can be assessed in this dynamic contrast MRI scan. It is helpful, especially in the response assessment in antigenic treatment therapies. For example, in this patient with HCC who was treated with sunitinib therapy, the DC MRI shows early changes in the K-trans or functional transfer cancer permeability of the tumor very quickly. That can help you to assess that sunitinib is helping the patient and patient responding to sunitinib therapy. One other modality one could utilize MR spectroscopy. It is helpful in the response assessment. It is not mainstream. It is still under a research algorithm. It can pick up changes in the tissue composition after treatment to see whether the patient is responding or not. This is a phosphorus MR spectroscopy, which shows reduction of phosphodiesterase within the tumor, but also enhancement or increase in the phosphomonoesterase. Phosphomonoesterase represent cellular membrane development. That means the tumor is growing, whereas phosphodiesterase reduction indicates breakdown of cellular membrane. So this patient, there's a mild reduction of phosphodiesterase, but significant increase in the phosphomonoesterase, representing the tumor is growing, even though radiologically tumor shows the same diameter without any significant change in the enhancement characteristics. So early recognition of the changes in the chemical composition of the tumor may give some signal to us whether the patient is responding to treatment or is not responding and progressing on therapy, which will help you to change therapy if required. And PET is not usually employed in HCC, but once the lesion is a PET avid, it usually indicates it is a poorly differentiated HCC compared to well-differentiated, which do not show any FDG activity on PET scan. And it also indicates that patients usually respond poorly to conventional therapies like TACE or ablations with PET scan. PET also can be used to assess complete response after ablation or chemoembolization. In this particular case, you can see this is a PET avid HCC, which was treated and then shows complete response on PET scans. Coming back to the newer modalities where dual energy is applied for diagnosis and assessing response to tumors. The main advantage of dual energy CT is enhancing the iodine quantification and also assessing the enhancement characteristics of the tumor at a lower energy of the CT. Normally, we obtain the CT at 60 keV or 120 kVp, which is equivalent to 60 to 70 kV. This is what the normal CT is routinely obtained, but this monochromatic imaging on dual energy CT allows us to scale back and artificially produce or virtually produce how it would appear if you were to use a low KeV energy to image the body. So as you decrease the KeV of the X-ray beam, for example, in this case, this is a 50, this is 45, this is 40. As you bring down the KeV of the beam, you can see much more superior enhancement of the lesion, a better appreciation of the lesion. So lesions that are less conspicuous on regular CT are better appreciated on the low KeV monochromatic dual energy CT imaging. It is also helpful in quantifying the iodine content of the area. So, for example, this area where the patient has a tumor in the IVC, very hard to see on this one. We don't know whether it's really tumor enhancement or not, but you can say iodine quantification. So iodine is present inside the area, which indicates it's an enhancing, and it is actually a tumor rather than a bland thrombus in the IVC. One can also utilize just a regular dual energy CT from the arterial iodine map and the portal venous iodine map, and then try to quantify the blood flow and mean transit and permeability constant, which is similar to the perfusion CT parameters what you get in a dynamic contrast enhanced CT obtained multiple time phases. Here, we're just using 2 time phases, but using a dual energy CT and quantifying iodine, you might be able to get a data that is similar to perfusion CT that can be used in diagnosing response tumors, as in this case, for example, a patient has a large tumor in the portal vein of the liver from HCC, and after angiogenic therapy, the perfusion CT obtained with dual energy CT shows significant response with the angiogenic therapy, with the reduction in the iodine content or enhancement of the tumor on the dual energy perfusion CT. Similarly, this is sorafenib therapy, you can significant reduction in the iodine content of the tumor, suggesting that the tumor has responded to sorafenib in this particular patient. One can also identify the actual volume of the iodine inside the tumor following conventional chemoembolization using Lepidol. Once you can quantify the iodine, if the tumor receives more than 10 milligrams of per ml of iodine inside the tumor, that usually indicates excellent response with a 95% chance of complete response in this patient population. So dual energy CT after conventional CT, conventional chemoembolization helps to quantify iodine inside the tumor. And if the iodine content is quite high, more than 10 milligrams per ml, that portends very good prognosis and very good response following chemoembolization. If you, for example, you didn't identify that much of iodine content in the tumor, it may be worth to take back the patient and redo the procedure. If you have, for example, you have a CT, an angio system, like a hybrid CT system, the dual energy compatible, you can technically do dual energy CT while performing the conventional chemoembolization and dynamically quantify as you treat the patient, and treat the patient until you achieve at least 10 milligrams of iodine inside the tumor so that you can get a good response post-embolization therapy. Other advancements in imaging is using a regular flat panel angiography system to obtain a CT-like images during angiography. So this allows to identify the tumors quite well. As in this case, you can see the DSC image, you can quantify, you can see the tumor quite well. And you can also identify the branches of the vessel supplying the tumor. This vessel and this vessel both are supplying the tumor, and they're well identified on this color-coded EMBO guide map of the same study. In addition to that, cone beam CT helps to identify smaller lesions, which are perfusion defects in this case, but you can identify very well on this CT, which you can obtain both in the arterial phase and venous phase. You can get a regular CT-like picture of the newer cone beam CT scanners to help identify not only the tumors, but immediately assess a response to your therapy. So if you were doing chemoembolization and your aim is to devascularize the tumor, you can repeat the cone beam CT at the end of the procedure to see you got the entire tumor, or if any other area is not treated, and you can identify the vessel supplying that area and then treat the patient before sending the patient home. So you can also use a 3-dimensional navigation system to help you to treat the patients, especially in ablation. So you can volumetrically assess the tumor, and you can create a margin of the around the tumor and color code them to help you to destroy the tumor in such a way that there is at least 5 millimeter margin in this case when we color-coded this area, we got a good ablation margin on this side, but on this side, we had a good ablation margin on a 3 millimeter margin. So we went back and re-ablated the lesions for the completion to get at least a 1 centimeter margin in our practice. The last thing is, other speaker also has expressed about the radiomics, artificial intelligence, all these things. The radiomics is a specific thing that is limited to imaging, where the imaging features that are not visible to human eye, but visible to computer, are taken into consideration to see whether those characteristics like a texture or edge enhancement or some vectors, all these things affect or can tell us whether the tumor is responding or unresponding to the therapy, or they can predict survival in these patients, or if they can predict a pathology. You could probably combine these radiomic texture analysis features with the known clinical data, cirrhosis, present stage, or laboratory values, or qualitative imaging features such as art enhancement, portal venous phase, or histological genomic analysis. You can put together all these things and then use them to see whether they can predict a specific outcome such as pathology or a therapeutic response or survival. So this is still under progress. A lot of papers have been published. One of the main limitations is that nobody knows which method is the best method, whether reproducibility is good or not. So over a period of next few years, we can see more and more of radiomics and AI in assessing tumor response and survival of this patient population. In conclusion, ultrasound remains the main modality for surveillance, and CT and MRI are the modalities of choice to make a diagnosis and further recommendations after identifying the lesion ultrasound. If the lesion does not fit into category of LR5, that is arterial hyperenhancement and portal venous washout, and lesion measuring more than 1 centimeter, then those lesions should be either biopsied or followed. And other newer modalities such as perfusion CT, perfusion MRI are helpful in assessing response to newer antigenic therapies. And Donergy CT is a new modality that has a great role in the diagnosis and management of XCC moving forward. With that, I conclude my lecture, and thank you very much for the invitation. Happy to take any questions.
Thank you, sir, for nice lecture. Now house is open for any questions. If no, then sir, which is the best option for LR3 lesion? Second imaging modality or biopsy or follow-up imaging?
So that's a good question. If it is LR3 and CT, and if you are not very happy with the image quality, then you can always get MRI to see whether it is still LR3 or it's going to LR4, because some characteristics of the lesion may be better appreciated on the MRI scan. If you already have a Donergy CT and that has shown a very characteristic, which is what you see in LR3, then adding an MRI may not add much to you. So in our practice, LR3 lesions are usually followed at 3 months' time. And we tend to change the imaging modality at 3 months. For example, if it's LR3 on CT and now, instead of getting an MRI immediately, we wait 3 months and get MRI at 3 months. That way, you get both the benefits of having a different imaging modality, and also you have waited 3 months at least to see tumor growth in this period of time.
Thank you. No more question, then thank you, Sanjeev sir, for very nice demonstration.
Thank you.
Now I hand over the session to Dr. Ashok for more any question answers.
No, it was very exhaustive and very interesting to learn both the speakers, as well as the case scenario excellent. I think Professor Sanjeeva and as well as partly Nolt has enjoyed the talk. It was a really challenging case also. So for your information, we do every month, second Tuesday, this interactive session with one case presentation is a real challenge as well as emerging topics. And next month also we'll join in the second Tuesday. And this is luckily today is the 10th. So we from single digit to become a double digit. So we hope we'll continue. Thanks to all, particularly Professor Sina and Professor Sarin and the whole APASL team giving this opportunity to carry forward. Thank you.
Thank you.
Bye.